So
Mute myself, sure.
yeah, so all speaker mute, and so that we can start. There will be no interruptions, inshallah. First of all, I'd like to say assalamu alaikum wa rahmatullah. The, this webinar of Symposium. Today also we are having international speakers. Dr. Carlos Matthew, Dr. Carlos Fabrizio, Dr. Ahmed Baqi, and Dr. Saeed. And this to be part of this webinar and being these eminent speakers. Before we start, just remind dear friends and we are listening to us now. Anyone want to ask a question, they have capability to listen to them and ask a question or to ask in live. So they understand a question and the same answer. Then we can just give the privilege so they can discuss with us and interact with us. The second thing is that anyone who wants to ask a question, so I don't want to just and answer the question. Just please write your question, the name of the speaker that you want you are questioning or asking this question. So at the end, we will have the ability to know this question is Carlos, Ahmed, and so on. The other things that also
Dr. Muhammad, the voice is not clear at all. Something, sorry to interrupt, but the voice is not clear, and I check with the other people.
Okay, okay, Dr. Carlos, Dr. Ahmed, Dr. Saad, are you hearing me nicely or not?
Now it's okay.
Now it's okay, Doc.
Now it's okay, but before it was.
Before there was, because maybe I'm a little bit far, but I can increase my voice. It's okay now.
No, it's not a matter of the voice. I think it was connection error. So if you can kindly repeat, because I think nobody heard the introduction.
Yeah, the beginning, exactly.
Okay, so now I will start from the beginning. Assalamu alaikum, everyone, and good evening. Today we are having an eminent international speakers from Spain, from UK, from Saudi Arabia, and from UAE. Dr. Carlos Matthew, Dr. Carlos Fabrizio, and Dr. Saad, and Dr. Ahmed Al-Baqi. And I'm proud to be in this international speaker. Okay, so you can hear me or not?
Doc, your internet connection, I think it's slowly.
Internet is connection, yes.
With me?
It's okay.
Okay, so and I want to repeat some instruction. If I want of not instruction, just a request from our colleagues. If they have any questions, they can send their questions. And anyone who wants to interact and to talk and with us, also he can just raise the hand and send the question, so we can just open the mic for him and we can have so send a message or a question, you can write beside it. He can write beside his question the name of the speaker. Okay, it's okay. For us, I have everyone is so many people that if there is any comment, let us send us I know they are not hearing us. Also, if anyone is not hearing us, before me about this one. I will be starting my presentation. I will be the first speaker of this presentation. I will have actually to talk about the real life practice dealing with diabetic macular edema. DME is it's actually is the most common leading due to diabetes mellitus and other things. So it's actually a burden, and it is more becoming more and more a case of, or we can say, more elaborated among the DME now, and how managed from the we are having a revision actually by having the anti-VEGF, then we are having the steroid. So this is just a review of, or a retrospective study. I have two presentations, a small presentation about this one. The first one will start with a review study. This is a called retro-ideal study. This study design is a multi-center study performed in 16 German centers. There is the inclusion criteria, which is the most important when we are talking about the illuvian, that they are insufficient response to anti-VEGF. So
Hello?
Hello, Dr. Alamri.
Yes, I think they have a problem with Dr. Al-Amri voice, I believe.
I think he's disconnected accidentally.
Oh, okay.
Would it be possible to move to the second speaker until Dr. Muhammad gets connected and internet resolves, John?
I think that's a good idea.
I agree. Yes. I think Dr. Carlos, I think for you, okay? He's the one to be next. But I believe Dr. Muhammad, he should end the sharing, right? Or
he needs to stop sharing.
Yeah, but otherwise, you guys can hear our voices clearly.
If you can end the sharing from Dr. Muhammad.
Yes, I'm trying now.
Yeah, I've done that. Okay.
Oh, okay.
But I mean, everybody else can hear the voice clearly otherwise, so it's his own connection?
Yes. Yeah.
Okay.
Okay, so we're certainly going to fix this minor glitch there, and we'll be able to go back to the first talk. So I'll be presenting some data from the Illuvian study, which was for non-infectious posterior uveitis, which is a 36 months data of this prospective randomized double-masked international study, which was conducted in two.
Dr. Carlos, you can't see your screen yet. You cannot see the screen.
Hello.
I seem to be sharing. You can't see it.
No.
1 second, Dr. Muhammad.
I can see it. I see disclosure now. I can see it.
Yeah, disclosures. You can see that.
Yeah, I can see it. Yeah.
Okay.
For me, not yet. I still seeing Dr.
For me, I'm still seeing Dr. Al-Amri's screen.
I still see Dr. Al-Amri.
Can you see that now or not yet?
I see it. At least I see it.
Yeah.
No, I think for no need, just to start. Okay, you can start.
Yes, now it's okay.
Yeah. Okay, so back to that again. Apologies for this. The study was involving, as I mentioned, a non-infectious posterior uveitis. So the main inclusion criteria would be patients who had a history of non-infectious uveitis for at least 1 year, and also had proof that uveitis was active. So 2 separate recurrences of uveitis requiring systemic therapy or local therapy or in the previous 12 months received treatment to indicate also that they had activity. These patients had to be adults, and when they were enrolled into the study, the eye had to be quiet. So the study was designed not to rescue an eye that was inflamed, but to treat an eye that had been quieted down prior to initiation of the study. The pressure was an important point. Pressure is controlled without medication, and no recent treatment with other devices that might interfere with the intervention. The important exclusion criteria was any form of infectious uveitis, or if the uveitis was only anterior. If the patient had vitreous hemorrhage or evidence of glaucoma or uncontrolled ocular pressure, then they would also be rejected for the study. Also, hypotony was an exclusion criteria. The main outcome measure of the study was the control of this. So what the proportion of patients who showed recurrence of uveitis by 6 months. The secondary points would be the recurrence rates at other time points, the time to first recurrence, number of recurrences, vision, macular edema, and number of adjunctive treatments that we're using, how did they behave once the implant was given. And of course, the safety endpoints, which included especially cataract and intraocular pressure, but also inflammatory signs and reduction of vision. This is how the study was designed. So once the patients were identified and screened, they were randomized 2-to-1 to receive the implant or a sham injection. And once that happened, they would taper their systemic treatment within a period of 3 months. They were followed up, and the first primary endpoint would be at 6 months, as mentioned before, when you have efficacy and safety analysis. The study continued up to 36 months when we have 2 other endpoints when the same analysis was carried out. Important to mention here that during the study, any patient from either group who had a recurrence of uveitis could be rescued by standard of care and then continue into the study. So we would analyze not only the time to the first recurrence, but a number of events that might have happened in the course of those 36 months. So the recurrences were defined as an increase in inflammation at the anterior segment, or vitreous haze increasing by 2 steps, or a deterioration of vision of at least 15 letters of best-corrected visual acuity. Everything was measured after the 7th day, because we have to take into account this was a surgical intervention in a way, and would it itself induce some inflammation in the eye. So the first days were discarded. This is the patients included in the study. We had 87 patients who started on the implant arm and 42 in the sham arm. And most patients completed the study, and down here in the table, you can see the reasons why the patients were discontinued. And you can see that there were no adverse events in either group, and lack of efficacy was only in the sham group as expected. But there were other reasons which were unrelated to the study intervention. This is just to give you the baseline characteristics of the patients in both groups. And there's nothing here which is significantly from the point of view of statistics, but it showed there was some features like duration of disease a bit longer in the patient receiving the implant, but a bit more of vitreous haze, a bit more of AC reaction or absence of AC reaction in the group receiving the implant, but nothing that reached statistical significance. This is the result of the 6 months, which shows that at that time, no recurrence in 72.4% of the patients on the implant arm, and only 9.5% with treated control. So within 6 months of having discontinued their regular treatment, having received a sham injection, 90.5% of the patients had already recurred. So that's this is the primary endpoint of the study. If we look at 36 months, then still about 35% of the patients remained protected without any recurrences. I'll show you some information about what happened to the other patients who recurred, but just to show you here that there's a significant protection from the point of view of developing an event. This is what happened with the Kaplan-Meier survival curve, which indicates that the patients who were treated with the implant had a median time to first recurrence of 657 days against 70.5 days of the patients who were treated with the sham. Also, the number of events they experienced during the time of the study, only 1.7 events for the arm receiving the implant against 5.3 for the sham arm. In terms of this graph, just to show you visually what happened, the blue, the light blue below indicates the patients who survived without any recurrence. And you can see very clearly that on the left, the implant shows that the patients had a much more significant protection in terms of recurrence comparing to the individuals who received the sham, who dropped virtually to only one patient just over 6 months all the way to the end of the study. This is the cumulative recurrences. So what you see here, that most of the patients didn't experience on the implanted arm any recurrences, like 34% had no recurrence throughout the study, but only in terms of what happened to the other patients, most of the ones who had a recurrence had just one recurrence predominantly. If you look at the treated arm, you had, as mentioned before, a high rate of recurrence very early on in the study. But if you keep looking at what happened over time, up to 40% of the patients ended up having more than 5 recurrences during the study. In terms of visual acuity, keeping in mind that rescue was offered if patients were experiencing an event, so it means that we're trying to protect the patients from damage. You can see that there was no change and no gain was very similar in the two groups, but clearly still a better protection from the point of view of the implanted arm. But when you look at the losses and gains, most of the patients who lost more than 15 letters were patients who were on the sham arm, and the patients who gained more than 15 were on the implanted arm. In terms of the behavior of vision over time, you can see that the group receiving the implant had a significant improvement very early on and maintained that throughout, with a little dip in the curve indicating mostly cataract. That is the reason why the vision drops and then increases again once these operations are carried out to deal with the problem. In terms of the macular thickness, you can see here that there is a very sharp improvement in the thickness of the macula in the implanted arm right at the beginning, which is maintained throughout the 36 months, which is the blue line down below the blue dot. If you look at the line above, you can see that there was some degree of protection, keeping in mind again that these patients were receiving injections as a way of protecting them from the events that were happening. This is in terms of adjunctive treatment. Well, the two groups received, of course, in the course of this, the study rescue. We know exactly what the frequencies were in terms of number of times they needed that. But you can see here that predominantly the patients on the implanted arm, 65% here had no treatment received. But then in terms of systemic, the numbers go to 34% of the patients were requiring some form of immunosuppression, against the sham arm that 50% of them required an intervention with systemic treatment. When we look at the intervention with local therapy, that brings a big difference. We can see that the sham arm received significantly more local therapy, which is an important event in terms of explaining some of the findings of the safety aspects, which we'll discuss with you in a minute. Here we go to the safety, and we can see that our major concern with any steroid injection in the eye is pressure. And we looked at this study, we can see there isn't really a significant impact of pressure when comparing the two groups. And interestingly, there is a more obvious number of operations in the control arm. And that is down to what I said before. Because they were receiving local intervention with other types of steroids, that was increasing the problem they were having with more significant pressure problems and eventually needing surgery. So in terms of the pressure, no real concerns shown by this study. In terms of cataract, yes, as expected, the arm receiving the implant had a much more significant number of interventions. So conclusions of this study is that the patients who received the implant had significantly more non-recurrence, so were disease-free, comparing to the sham arm. The time to recurrence was significantly different, much longer time for the first event to occur. The number of the recurrences were also reduced in the arm receiving the implant. And the treatment of recurrences were, in terms of local therapy, much more given to the sham arm, which explains some of the problems they had later on. Safety is what I mentioned just now, that IOP is well controlled in both arms, so not a real problem. And cataract, of course, a significant issue related to the implanted eye. I think this will bring me to a second presentation, which will deal with let me just bring this over to you now, with the cases I was asked to show you with real world experience. Because the problem we have with trials is that they are looking at a group of patients under the label of non-infectious posterior uveitis. And here we don't know exactly for individual diseases what happens. So I'm going to give you a very quick flavor of some patients that I've seen, and one case from a colleague who kindly allowed me to use it because it's a very illustrative case. So I'll show you here this first case. It's a lady who presented to us, a lady in 58 years old with floaters as her main complaint, with very good visual acuity, but disturbed by the floaters. So the examination was in keeping with a retinal vasculitis affecting both of her eyes. We attempted to treat her systemically. She wasn't responding well or tolerating well her treatment. And then we went on for the option of local therapy with Iluvien. So this is how she presented. You can see the vitreous involvement is the reason why she was unhappy. We can see in the angiogram, she had very marked diffuse retinal vascular leakage in both eyes and the presence of diffuse edema also in both eyes. This is a picture taken back a few months later on. During this time, she was trying to treat her with systemic therapy, but there are many reasons why she wasn't coping or the treatment wasn't working. So we can still see the same level of activity. At this stage, we decided to try Iluvien. So she had the two eyes implanted, very short between the two. And you can see here an image. At the top, the image you've just seen from January, which shows there's still the leakage in the eyes. The image below is from a few months later, in August of the same year. And you can see already an impact of the Iluvien in the level of leakage that was happening in both of her eyes. This is an image taken in March 2017, so about a year after the implants were given, and you can see that there is a marked control of the inflammation and an improvement in the status of the macula with some thickening related to an epiretinal membrane. We go here for images taken now April 18, so we are 2 years into this implant now, and she's much happier with the fact that she doesn't have much vitritis. The level of leakage in the retina is better controlled. The areas of hyperfluorescence you see there are areas in which there's more RPE abnormality rather than retinal vascular leakage. And we can see here, this is September last year, which means this is over the 3-year duration of the implant. And this is the image we have. So this is a case in which implants in both eyes led to good control over inflammation over a period of time above the 3 years for which the implant is designed to work. The second case is a case of birdshot, which has a retinal vascular component, very similar in many ways to intermediate uveitis or retinal vasculitis, but it has also a choroidal inflammatory component. And this is the problem in this disease that I want to show you here. So this patient came also with a lot of problems related to her systemic therapy, not actually tolerating the treatment very well or having side effects that had to force the discontinuation of therapy. So effectively, she was not well inflamed. When you look at his eye, and you can see the vitreous is a very good view. The autofluorescence doesn't show any significant changes at this stage, and pay attention to the autofluorescence because I'll show you later what happens to her. And we can see here in her angiogram that she has very minor focal areas of leakage, and the shadows you see there are from the vitreous opacity. She had a good macular thickness, not actually having macular edema, but her choroid was obviously inflamed with the presence of the typical birdshot lesions obviously seen on the ICG on the right. For both eyes is a very similar picture. So she was at this stage, because she was intolerant to everything else, and she was very worried, and we were worried about her choroid as well. We decided to give her Iluvien to both of her eyes. So what happened, we can see that she doesn't really show much in terms of retinal vascular leakage. It's improvement from that point of view. And what we see is the choroid looks unchanged. So she still had choroidal lesions in both of her eyes. We can see what was worrying to us is that apart from having the choroidal lesions seen on ICG, her EDI OCTs were showing the choroid was markedly thickened. So we were concerned that the Iluvien, even though controlling the retinal vascular leakage very well, was unable to achieve control of the choroidal lesions. So effectively here we can see how well the retina looks on top of a choroid that is markedly thickened. So at this stage, there was a decision that we had to do something else for her because the picture didn't seem well controlled. And if you look at these images here, pay attention to the peripapillary area on the autofluorescence. You can see that comparing to the initial images I showed you, something is happening involving the RPE in that area. So indicating that that choroidal inflammation is having an impact on the outer retina. So this is very obvious here on this image when you see that the retinal vessels are not leaking, but the RPE shows obvious abnormality. That happened in both of her eyes. So she was giving adalimumab, and adalimumab led to a progressive rescue of the inflammation of the choroid, and the situation improved. As you can see here, the images showing how she behaved under adalimumab with resolution of the dark spots in the choroid in both of her eyes. So the message here is choroidal inflammation has to be well controlled, or it will eventually damage the retina from the back. So it's not only controlling the retinal vascular leakage, but controlling the choroidal inflammation is important. And unfortunately, it doesn't seem that Iluvien can help us with that. But the use of Iluvien in combination with systemic therapy would allow you to use less systemic treatment, which the combined treatment leads to less side effects and better control of the inflammation in both compartments. Very quickly here, I'll follow the final case, which is very illustrative from Mr. Thomas Burke, a colleague from Bristol, with a patient who had anterior uveitis and macular edema, secondary to poor control of an HLA-B27 scenario, leading to a chronic presentation. And this patient also had problems with systemic therapy, ended up receiving many intraocular injections to both of her eyes, and had to be commenced on adalimumab. When she was treated with adalimumab, the situation was improving, but unfortunately, she developed a side effect and the treatment had to be stopped. So after that, she developed inflammation in both eyes. You can see here more cells in the right eye, and eventually developed a lot of inflammation in requiring the use of Ozurdex in the right eye. The right eye responded very well, but you can see that the left eye now is inflamed with macular edema, and Ozurdex was planned for the left eye. Left eye was injected, got better, but 4 months after the Ozurdex in the right eye, the situation deteriorated again. So she was forced into being treated again for the right eye, and the left eye lost control. So in summary, you can see this very illustrative image indicating how many times she lost control within a few months of each injection of Ozurdex, requiring further injection. At this stage, we was feeling that Iluvien would be a good alternative, still off-label at that time in 2014, and she received injection to both of her eyes with good control of the inflammation bilaterally. The graph illustrates very well that bizarre behavior up and down with the Ozurdex was corrected by the Iluvien, leading to a very stable situation. The problem is that after 2 years of the Iluvien, she still under control, but the situation deteriorated after the 3rd year when she had a very severe flare-up of inflammation in her left eye. Decided to implant again, but this time the implant didn't work. And the conclusion was probably they dropped the implant on the floor before they injected in the eye, which can happen if you point your device downwards when you are holding it in your hand. They couldn't find it in the eye, not even with a B scan. So they decided to proceed with another injection of the Iluvien, which would be effectively the 2nd, not the 3rd. And what happened after that is that we again achieved good control. So this illustrates very well the ability of this implant over a period of time of 3 years to allow patients to reach control and avoid these ups and downs of inflammation, which are not uncommon in this scenario. I hope this concludes my presentation. Thank you very much.
Thank you very much, Dr. Fabrizio. I hope that you are hearing me now.
Yes, that's good.
Thank you. Sorry for the problem that happened. I think because I am in the hospital and the internet is not stable. So I'm sorry for that again. If there is any question from dear colleagues here to Dr. Fabrizio, Dr. Ahmed, Dr. Saad, Dr. Carlos, anyone want to ask Dr. Fabrizio about his presentation? No questions? Can you hear me, Dr. Fabrizio?
Yes, I can.
Okay, Dr. Fabrizio, you are having a good experience, as I know, in treating a patient with uveitis. How long now you are using Iluvien in treatment of uveitis?
Well, I've been using Iluvien even before it was licensed, off-label use for my patients, because I felt it was a good alternative. As you can see, the cases I presented were patients who were intolerant to systemic therapy or were having trouble with the doses necessary to control the disease. So we've been using it for several years now. I have patients who are on the 2nd implant and going towards the end of that 2nd cycle. So we have been using for about 6 years that I've been implanting these eyes. The experience has been mostly positive with patients with retinal vascular leakage, so intermediate uveitis, macular edema. These patients respond very well. Clearly, what I showed you here, which is a good important message for everyone listening, that choroidal pathology does not seem to be treated by this intervention. And it's important to remember that, because if you allow the choroidal disease not to be treated, as you know, in many choroidal diseases, you end up damaging the retina. So important is, if you have a patient needing a lot of medication because it can control the vascular leakage very well, using an Iluvien implant may help you control that and reduce the burden of systemic therapy, which for choroidal disease may be on a lower level necessary for that.
In case of uveitis, how do you decide, or select the patient, and what is the time you think it will be similar when you are treating DME? It is now we're not talking only about DME itself or the macular edema, but we are talking about uveitis now. And so there is another things that we are dealing with. So when we are talking about DME, we are saying 3 years. How do you feel in case of that? Or according to the severity, how do you manage to decide what you are going to do with this cases?
Okay. I think the first message is important, is you're not using Iluvien to rescue an active uveitis. So if you have a patient who is very active, it may be very hard to say that the drug is not licensed for that. So you can have trouble saying that you can control a very active uveitis. But the point of the study and what we try to do is bring it under control with other methods. And once you have control, you introduce the Iluvien to be able to prolong the control over the duration of the effect of the implant. So we may try systemic therapy. You may try even using a Nosardex first, and then in continuity to that, applying the Iluvien as a way of maintaining that control. It's very variable what you see. At the moment, we don't have enough long time data to say the duration of the implant efficacy. People are reporting that some implants fail after 2 years. I've just shown you a case that the implant's still active after 3 years. So it's possible that we have a range of effects that will vary in time. We know with those Nosardex that for us, in 3 months, most of cases, 3 to 4 months are failing. So it's not going to the 6 months, which was originally the idea. So I use Iluvien when I want to reach long-term control, but I may not use it as a rescue therapy. I use it as a maintaining control rather than rescue.
There is another thing comment about this one, Dr. Fabrizio. Now when you will decide that you are using another method of treatments like dexamethasone, so or something that you depend to shift to Iluvien or to keep the Iluvien as a maintenance?
Yeah, well, in terms of other local therapies, you just mentioned the dexamethasone. So the dexamethasone is likely to work in many patients. And if you use it and it works, that would be for you a proof that local therapy is a good alternative. So rather than repeating several Nosardex over time, you may very well decide that after 1 or 2 injections, you know the behavior in that patient, and you know that you'd like to use something that will prolong the effect. So I would say, yes, try one first, see how they behave, and then you can replace that approach with Iluvien. Systemic therapy still is very commonly used in uveitis. Depending on the nature of the disease, it still is the best alternative. So we don't say that Iluvien comes in to replace everything else. Iluvien is a very interesting option, which can be selected for a few patients who will have disease for which you want to control, reducing the burden of exposure to systemic drugs, and patients who have shown that local therapy is effective. So I think it is probably exploring your options. And if patients are suffering side effects, not tolerating the level of treatment you're given, if you try a Nosardex, and if they respond to that, you can then consider Iluvien as a very good long-term alternative for you.
Okay, so because we have many questions, I have now many questions coming from our attendees, but I want a very short as possible the answer.
Yeah, sure.
What was the testament after the Iluvien for case number 2?
What was, sorry, the assessment?
Yeah, testament. I think he is meaning treatment after Iluvien for case number 2.
Oh no, the patient who received, the patient I showed you here, that was the birdshot patient, that lady was intolerant to any treatment. She was only receiving Iluvien until we decided that because of the choroid thickening, she had to receive adalimumab. So for most of the time of the images I showed you were based only on Iluvien. She was not able to take anything else. The moment we were unhappy that the choroid was not controlled, she had adalimumab.
Okay, there is another question. Did you notice any difference in response in various non-infectious uveitis disease?
Difference in the response?
Yeah,
well,
the different type of non-infectious.
Yeah, the trial did not allow us to analyze the subtypes of uveitis because the numbers are small for each category. So we don't have a specific situation when I say to you that Iluvien will be better for one or another disease. What we know now from experience is one point is this: not good for choroidal disease, but very good for diseases inflaming the retina, the vessels, and macular edema. So that is a very broad division, but I can tell you about specific disease. I would not treat VKH, sympathetic ophthalmia, with an ILUVIEN. I wouldn't treat Behçet with an ILUVIEN because they need systemic treatment. So there are a few things that are still the same as before.
Oh, we have another also. Did you try Ozurdex before using ILUVIEN, and at the same time, did you also try to use Ozurdex as a test or challenging test before starting?
We have. You see the patient here. I've showed you two cases in which one case at least, the patient had Ozurdex responding very well, but lasting for a short time. So the decision to change is because of that up and down we had. So we do try Ozurdex first. That's very much what we try if they're very active, because they want to bring it under control. What you find is, because ILUVIEN works better if the eye is already quiet, you can give an Ozurdex, wait for that to quiet down, and when you know the Ozurdex is about to fail, which could be 3 to 4 months, you can then inject your ILUVIEN, which would then allow you to maintain the control long term. So yes, I think trying that is an option. It's how the way to do it.
We have only 1 minute before then we can shift to another speakers. We are in some cases after ILUVIEN injection, I'm not able to see the implant, even in the periphery. What may be the reason? I think you have you talked about this one and you repeated, right?
Yeah, we all see that. The first time you do it, you panic because you think you didn't inject in the eye, as it happened in the case of I described to you. They actually did not inject. But yes, it can go in the periphery, very peripheral. Using indentation, you can probably see it. But in a few patients, I have one case that only ultrasound demonstrated that it was in the eye. So it is probably because it doesn't go into the vitreous, it may slide just above the hyaloid and remains very peripheral and anterior. So it's very hard to see, but it's working. So it doesn't matter that is in that location, it's going to work.
Okay, so the last question, but very short answer. Is it possible that Ozurdex would be effective and not ILUVIEN in the same case?
No, we have patients in which we have injected Ozurdex for choroidal disease. For instance, it didn't work as well. So Ozurdex does not treat choroidal disease. And patients in which Ozurdex fails increases significantly the risk that your ILUVIEN will not work. I think there is a good chance that if your Ozurdex has no impact, that ILUVIEN probably won't have an impact either.
Thank you very much, Dr. Babizio, for this.
I have just a comment about, if it is possible, about the
yes,
the
Dr.
question.
Ahmed, I asked
the question.
if there is any question, but nobody.
No. Comment about the question that been asked by one of the attendees about sometimes you inject ILUVIEN and you cannot see it in the periphery.
Mm-hmm. Yeah.
So in the term of injection, if you look at the injection technique of the ILUVIEN compared to versus Ozurdex, you have the two-step technique, so you might miss it or somehow. But with ILUVIEN, if you properly load it, you make sure that it's properly loaded and to stick to the rules of the two-click technique, because you go straight direct. There is no two-step because of 25 gauge, so you go straight ahead inside the midvitreous cavity or inside the vitreous cavity. With this lens, you are 100% sure that the implant, it must be inside the eye. So this is no risk to be out, except if you improperly load the injector. So if you properly loaded it properly, and you make sure that the plunge push it inside, also you are sure, because you are going straight ahead. So unless if it is not in the lens, so it's inside the vitreous. So
okay, thank you. Thank you, Ahmed, for this comment. Can we now? Okay, Ahmed, also it is your now time for your presentation.
I think your presentation, because we swap between you.
No problem. I will do it later on. I will do the last. This is I will see, inshallah, the internet. I don't want to have the same problem and we lose the time.
Okay.
So go ahead, please, Dr. Ahmed. Thank you.
Can you see my presentation now?
Yes. Dr. Ahmed is a retinal surgeon, consultant in SKMC. Dear friend Ahmed, please.
Thank you, Dr. Muhammad, and I want to thank you all my colleagues. It's a good, it's a pleasure to be here today, and also thank Alimera for hosting this meeting. So just to be quick, I'm going to share with you my experience, or our experience with ILUVIEN and the DME and UE. We have recently published the 6-month data for the rapid structural and functional improvement. For sure, it was published in January and available online. It's free if you can access to it, or can send it to anyone who want to have a look. For sure, it's 6 months. It's short duration, but in this manuscript, we focus on the rapid structure and functional improvement, because it was interesting and surprising for me that in most of the cases, the action or the onset of action was so fast, and I will go show later. So now we are submitting the 1 year data. It's still under review, and also this 2 years data now we have, which I'm going to share with you today. So in our trial or our study, we have 20 patients, DME patients, pseudophakic, all were pseudophakic. We exclude phakic patients, and we treated with Iluvien, and the patient was monitored as most of the study for the 1 month, 3 months, and until 24 months. For sure, the parameter was used as biscular visual acuity, central macular thickness, and intraocular pressure for sure. Here, this is the baseline characteristics and demography of the patient. What I want to highlight here is the duration of DME was a little bit fresh one. It's not like in FAME trial. And if you look at the result, actually, the visual outcome was significantly improved. We have most of the patient gained more than almost 15 letters. And this is for the 1 year data. And then for the 2 years, it was maintained over the second year. We have 5 patients who require top-up therapy to maintain the initial gain. And some patients gain also additional line in the second year. For the anatomical outcome, it was reflecting or mirroring the gain in the visual acuity. You can see here it was maintained to all the second year. Again, this is just to combine both together, the visual acuity with intramacular thickness. It was, for me, it was a good result. IOP, we have IOP rise in 3 patients, and if you calculate it in percentage, it's matching with the common percentage of the IOP rise in other trial with Iluvien. We have 1 patient that had need glaucoma surgery, which was done by our glaucoma consultant with implanted Ahmed valve. And we can hear what I want to show you, that the onset in most of the patient was starting 2 to 4 weeks after administration. And maybe someone asked, do you bring the patient after 2 weeks only to see the result? The answer is yes. In special cases, when you have a new drug in your hand, you really are eager to know how it's going on. So we brought it after 2 weeks and then after 4 weeks, and also check the IOP. And surprisingly, there was a great improvement at week 4. And this gain was maintained over the 24 month. 90% of the patient actually maintained this drying effect. And so for the sake of time, I want to share you some cases, some of the study and 1 case outside the study. And the reason I'm sharing this case is because it reflects really what's happening in the real clinical practice, because in real clinical practice, it's sometimes different, most of the time different than the clinical trial. So the case 1, it will present a non-compliant patient. So let's see, have a look. This is a 54 patient, female patient, poorly controlled diabetes. That's a common rule here in our area. Visual acuity 2100. You can see here cystoid macular edema. So we start for here as a first line anti-VEGF. After 2 monthly injection, the patient, the macular was dry and the vision improved. But we asked the patient, we continue injecting for at least 5 or 4 injections, but the patient didn't show because he improved the vision. And also this patient was a little bit panic from the needle and the injection, despite all the psychological assurance happened. But anyway, he didn't show up. So he came back 4 months later for recurrent edema with worse visual acuity. So we explained to him again, we need to stick the treatment. You are a good responder. We need to keep injecting, and we have to come to you on your appointment for injection to be compliant for your, because recurrent edema, it's have a negative impact on the final outcome in the long term. So another anti-VEGF injection, and 1 month, you see here how beautifully the macula dry. So we discussed, we have to continue the injection. But unfortunately, again, he disappeared. And again, the edema came again. And if you look, every time the edema recurred, the visual acuity was worse than the other recurrence. Another anti-VEGF, 1 month again, and it proved. So this patient is a very good responder to anti-VEGF. Despite this being non-compliant, when I appear this show after 3 months, you can see here how the edema is 2400 and the huge edema. So for sure, I discussed with her, sorry, we need to change to a long-acting drug. So since you are not coming, want to come to regular, so we switch here to intravitreal dexamethasone implant, and 2 months post-injection, beautiful result, visual acuity improved, but we start to have some macular buckling there. 4 months later, edema recur again. So definitely this was a good, I discussed with the patient that since we have no issue with the IOP, so I switch her to 11, and 2 weeks, I want to show you 2 weeks post-injection. You can see here improvement is a good improvement, like 50% improvement. And 4 months, you can see here 12 months and 24 months now, this 2 years one study. You can see here visual is improved, not to the maximum for sure, because this patient has some issue about the photoreceptor and the ellipsoid zone and some macular buckling, but the vision was, and it was stable, and the macula was dry for 24 months. Second case, this was more easy to decide because she's already poor control diabetes also. So coming for me, second opinion, she has multiple intravitreal injection in the last year, and also intravitreal dexamethasone implant twice. And the last one was done 6 months before. So when she came to me, this is what the presentation, visual acuity 2400s, IOP was normal after 2 injection of dexamethasone implant. So my decision was to go direct for fluocinolone in this case. And you look here, 3 weeks, 3 months. And I want to have your attention here. If you look here to the hyperreflective dots, which I really consider it in my treatment. This could be a sign, and we have many publications that could be a sign of inflammation. Anyway, so 6 months, you can hear it's getting dry, but also the retina is very thin. You can see atrophic changes from the laser, but the macula is dry. 12 month post-injection 2080, it's a very good visual acuity. Some cyst here, but the central is dry. And 27 months, this is the longest follow-up I have till now, 2080. And by the way, I mentioned in the study that one of the patient has glaucoma surgery, and this is what the patient. This patient, despite the fact she received 2 injection of dexamethasone implant, she didn't develop any glaucoma or high IOP, but she developed with 11 IOP. Her eyes was not controlled, and we have to do surgery for her. And now the pressure is controlled and the macula is dry. And this give you an idea when I discussed this with our glaucoma consultant about the steroid challenge, generally speaking. Steroid is a big family, but has a lot of member. So does not all behave the same. So it's not 100% guaranteed. For sure, challenge test is very important, but it's not 100% sure that if you switch to another steroid molecule, that you are 100% safe that no rise of the pressure. So this was interesting for me. Case 3, this is also one of the real case data that show us the strategy or the concept of individualized treatment. If you look at this patient, he's 69 years old, diabetic, non-controlled, a lot of comorbidity, history of a stroke 1 month ago only at that time. Came to me, hemiplegic on a wheelchair from ambulance from outside the city, 3 hours drive with his son, complete decreased vision in both eyes. On examination, his visual acuity was 2400 in both eyes, pressure was okay, dense cataract in both eyes. OCT was done. You can see his macular edema in the right eye, and this is in the left eye more severe. And if you look, there's some videos that I want you to show you the whole scan of the macula. You can see here a lot of hyperreflective dots also and the hard exudate. So what's the plan for this patient? So when I think about this patient with his specific situation, the plan, you can go for anti-VEGF or steroid. So for anti-VEGF, I was a little bit reluctant to do that because just 1 month ago has a stroke. And patient comorbidity, he's hemiplegic, he's coming from far, he cannot come for monthly visits. So the decision was to go direct for intravitreal dexamethasone implant. I discussed with the patient for sure the risk of IOP because he's already has cataract. So the only thing that we might have rise IOP, so we have to continue or to follow up the IOP at home city just to check for any rise of pressure. So injection was done and asked the patient to come after 3 months, but he didn't show up because of this case. He came 6 months later. So you can see here the edema recurred again, 2400, and also have a look on the hyperreflective dots here. the same, and you can see the quality is poor because of the cataracts. So at that time, we decided to go, and the pressure was not high, so it gave me the chance to plan him for a combined phaco with intravitreal fluocinolone implant for his specific or special case. And 1 month later, you can see more the image was more clear because we removed the cataract, the edema improved, and again, a lot of hyperreflective dots here. You can see very obvious in the left eye, and this is the pressure does not getting high for thanks God. Everything was fine. 9 months later, you can see here again, the vision is improved, getting more improvement, getting more dry. Still have problem with the photoreceptor layers and ellipsoid zone. Pressure is okay. Case 4, it's very interesting. It's not a case including the study because she was phakic patient. She was a female, 50 years old, 55 years old.
The last case, Ahmad?
Yeah. Last case.
Yes.
Uncontrolled, decreased vision in the right eye 2 months ago. If you look at the examination, visual acuity was in the right eye 20/50, pressure is okay, clear lens, OCT showed this cyst. Sorry. So we start for sure anti-VEGF. So I start with ranibizumab, and after 3 consecutive monthly injection, there is no change at all in terms of visual acuity and OCT. You can see it's like copy paste, no change, zero change or zero improvement. So for me, I'm following the post-canal protocol eye that after 3 injection, I decide to change or to switch. But in this case, I was at that time switched to aflibercept. And after 3 consecutive monthly injections, so it means 6 monthly injection of different anti-VEGF, exactly the same visual acuity, the same picture you can see here. So what's the plan now? I discuss, sorry for this kind of patient, if you inject 6 in monthly injection and no improvement at all, usually I do FFA for those patients to check if there is any other pathology hidden. So this is the early phase video of the FFA of this patient. You can see here some leaking macular aneurysm. There is nothing abnormal at all. You can see here, this is the first 2 minutes or 1 minute of the drug. So it's only just a leaking macular aneurysm. And if you look at the picture, you can see it's a typical case of focal leaking macular aneurysm, but inside the very close to the fovea. So there is nothing abnormal there. It's just macular diabetic macular edema. So what's the plan now? I discussed with her to go for dexamethasone implant. I counsel the patient for the risk of IOP and cataract, but for sure the patient does not want injection, because if I were in her shoes, I would do the same, because after 6 monthly injection, no improvement, what make me do another treatment and try another one? So I tell her, okay, let's follow up. She came back after 3 months, and you can see here the visual acuity decreased and the edema increased and the visual acuity dropped. So at that time, we decided to go for intravitreal dexamethasone implant, counseling the patient for the risk of cataract and IOP rise, agreed. I give intravitreal injection, and interestingly, 1 month post-injection, you can see here, 3 months, no change at all. And even 6 months, it's getting worse, but the pressure does not increase. So the question here, what to do? Again, I discussed with her that the only medication now we have in our hand is the fluocinolone. Can we try it? But there is 100% or 80% risk of cataract and IOP rise. I again counsel it for IOP rise, despite the fact that it did IOP rise after dexamethasone implant, because I learned from the first case I show you before that it's not 100% guarantee that if you use a challenge test that is the pressure will not rise. So I offer her all things good, but the patient agreed for the treatment. So let's try the fluocinolone, and interestingly, after 1 month, the macula was dry a little bit. 3 months was stable with some changes here. Visual acuity is improving, and the IOP is lutein is not increasing. But 9 months later, you can see here, starting the edema recur again a little bit here. Vision is a little bit dropped, but the cataract for sure increase. So, and the question now to the panelists, what to do next. So, just to take home message from my talk, what I want to highlight that we are not curing the disease. We are just treating the DME, which is a complication of the main ghost sitting there, which is diabetes. That's a challenge. Another thing, there is something still missing in the pathogenesis, because if it is only VEGF mediated or inflammation, I think most of the patients will respond for either of this medication. But if you see the last patient I've shared with you does not respond to any of these. So I think, and I believe that you are not aware about the new drugs now in the pipelines. They are targeting now the endothelial cells, not only the extra cellular vascular VEGF pathway. They are now more targeting the endothelial cells. And one more thing, the last thing is one size does not fit all. There is no single medication that can treat all type of diabetic DME. We have different response pattern, uncontrolled, a lot of comorbidity. So we still have some unmet need and some challenges, but we have, for my opinion, the best way to treat the patient is to individualize the treatment, to treat the patient just sitting in front of you in the sit lamp. And thank you. I hope that I stick to my time.
No, you are exceed anyway, no problem, but we'll have the question at the end because we are running behind the time because of my problems also in the beginning. So now I will go directly to a doctor. If there is any question to Dr. Ahmed Al-Baqi, or you want to keep to the end, it will be more better. So I can go now directly to my dear friend, Dr. Carlos Matthew. He's a consultant ophthalmologist, vitreoretinal surgeon, associated professor of the Master in Retina and Vitreous at IMO, Faculty of Medicine of the Autonomous University of Barcelona. We are proud to be, and we are glad to have you, Dr. Carlos, with us. Can you just unmute yourself and start?
Okay, Mohammed, I think you can see now my presentation.
Right.
And thank you very much for your kind invitation. Let me change the topic. You know, I do mostly vitreoretinal surgery, mostly at medical retina. Then I'm going to show you three topics, three small cases, you know, very short cases. Two about myopia and one about illuvion. In the cases we use illuvion in some cases with severe hypotony, trauma, PVR, something like this. You know, let me share with you the very first case. The very first case is a macular hole with schisis. You can see here is a 49 years old female with high myopia. Right eye is 30 millimeters of axial length. Left eye is 32.2 millimeters, and there is a posterior staphyloma mostly in the left eye of 2.4 millimeters in height, measured by B echography. And the patient came to me, sent by another surgeon, just to, you know, think about macular buckling in a case with 6 months progressive visual loss and metamorphopsia. You can see visual acuity was 20/125, and as you can see, here you have a posterior staphyloma, some RPE, you know, disturbance in the posterior pole, and here you can see a full thickness macular hole with a schisis, the posterior highlight, the schisis of posterior highlight. Then, you know, this was 3.5 years ago, and I was doing, you know, macular buckling for these cases, to change to do only inverter flap for these cases. Then, you know, was my first case. I convinced the patient to change because many surgeons say that, you know, you don't need macular buckling for these cases. And I say, okay, let's try it. Let's make a series of cases doing this surgery without macular buckling. Then, you know, I convinced the patient and I did my surgery. You know, this is a phakic patient, as you can see. We did, you know, 23 gauge vitrectomy, and you can see we removed the vitreous there with the 23 gauge. I use only one light. You can see here something that may resemble, you know, the Weiss ring, and then we remove the vitreous, you know, and it's very easy. Then I stain. I never use triamcinolone. I have to tell you, many surgeons in the world, they use triamcinolone. I always use brilliant blue, yes, from the very beginning. And then you can see here how, you know, the posterior highlight is attached in the inferior arcade. You know, I think to speak about, you know, posterior vitreous detachment in these kind of cases, this is a mistake. You can see the macular hole there, and then the posterior highlight, in the majority of these cases, they stay attached to the retina. Even if you see a ring just floating in front of the optic disc that says Weiss ring, don't believe that, you know, the highlight is detached. Because this is, you know, posterior highlight staining is very typical. You know, it's irregular staining. The posterior hilum is very elastic. It's difficult to control where you go. You just pull, and you know the posterior hilum comes to you. And here there are three questions for me, because there are many surgeons that say when there is these kind of cases, they try to remove the posterior hilum to the extreme periphery in the cases of myopic maculopathy. You know, and I tell you, my opinion about this is not to do it. You know, I try to preserve, you know, the peripheral retina for any break. You know, I don't try to go to periphery, because in these kind of cases, in some of them, they have very strong attachments of the posterior hilum, then you can promote breaks. And you convert a myopic maculopathy to a retinal detachment in a high myopia. This is a terrible thing. And what would be the next step? The next step for me is to re-stain, to see perfect, you know, the internal limiting membrane. And this is, I always use only brilliant blue. You see here, perfect the internal limiting membrane. And we start in the inferior part of the retina, as you can see here with the forceps. And then we make a rhexis around the macro hole. I try to decrease the pinching numbers, you know, you not try to pinch and pinch. I try to, you know, make the less pinch as possible. And then we put all these ILM around the macro hole. We are creating now the superior to inferior flap, just to cover, you know, the macro hole. My advice is don't press down. You don't need it. Don't try to put the, you know, the ILM inside the hole, because you can promote, you know, RP lesions. Don't press down. You leave it there. And then my question to you is, could anyone have done something else? Because there are some surgeons that say that in these holes, you know, the viscous fluid inside the hole perhaps prevents macro hole closing. You know, and I did. I went with my 41 gauge camera before to peel the ILM. I went to the, just inside the macro hole, you have to be very stable, just to, you know, exchange this vitreous, you know, this viscous liquid fluid inside the hole. And then after this, I started to peel the ILM I showed you before. Okay, after this, we trim the ILM. As you can see here, how to trim the ILM. Lower your cutting rate and lower your suction. This is the most important thing. And then when you aspirate in the inferior part of the retina, because all the fluid coming down from the peripheral retina, peripheral vitreous up and down, you know, make a current and maintains the flap, the superior flap over the hole. You know, some surgeons, they make, you know, the temporal flap, but, you know, at the end, my patients, if they are, you know, walking, then, you know, I prefer the flap to be from superior part to inferior part to be maintained there and to close the hole. And then I'm sure you're expecting a perfect closed macro hole. And, you know, this is the perfect inverted flap, but, you know, the macro hole remain open. You know, this is 4 weeks after the surgery. The patient was very angry with me because I convinced her to avoid, you know, macular buckling and only do this, because many surgeons told me that, you know, in many meetings, they say that you don't need it. You know, at the end, this acuity was 20/200. And what's the next step? Well, the next step for me, first, why did it fail? You know, you have any explanation about this? And the next step, of course, you know, I did macular buckling in this case. And then, you know, macular buckling, just to remind you, this is, you open the supratemporal quadrant, then you put a matrix suture pointing the macular area where you think there is the macular area. It's not that easy because it's, you know, huge variation. And then I went there to just to see how was my inverted flap. And my inverted flap was there, was perfect, you know, was over the hole. And then I began to touch my flap, and at the end I lost the flap. You know, the flap was a free flap, and then to put the flap again inside the hole is so difficult. Let me ask you, what is this? Let me ask you, what is this bubble? You know, I expect your answers. Then with two flexible loop, I went there. This is not that easy. Then the trick is to put again under perfluorocarbon liquid the flap, and then very, very softly you drag this ILM flap to put the flap into the hole. Look at the bubble I showed you before. You know, this gas bubble over the perfluorocarbon liquid. Then we put this Macular buckle. I think is the best buckle. The buckles I tried. There's a light in the platform. You can see the blue dot there. But at the end, when I remove the perfluorocarbon liquid to final exchange, then you know the blue dot disappears. And then I didn't have any flap over the Macular hole. Then I make a fluid exchange, SF6 20%, and the Macular hole was closed. Visual acuity was not fine. This is 3 years. This is not the aspect of 3 years. I don't have here's the aspect of the schices have disappeared, but visual acuity remains in 20/100. This is not a good result. But let me confess that was my first case doing the inverted flap in cases with Macular hole and schices. I did it with Macular hole without schices a lot of time ago. And the series continues. And as you can see here, we were able to close. This is the first case I showed you before. And as the series continues, these are 8 cases here that we were able to close the Macular hole. Well, to say to close the Macular hole is, look at the last case. This is 6 months ago, and this is a perfect visual acuity is 20/63. This is a very good 20. Excuse me, it's not 20. 2032, and visual acuity was very nice. 2032, as I told you, but the Macular hole remains open. The patient, has decreased metamorphopsia, and it's perfect. And we are expecting this to close spontaneously. The second case is a nightmare. Let me ask you about if you have seen any case like this. This case is a Macular hole without schices in a high myope. This is a 53 years old female, high myopia, radial keratopathy when she was 18 years old, and 1 year ago she was operated cataract surgery and IOL implantation. She showed 15 days moderate visual loss and metamorphopsia in the right eye, and visual acuity was 20/50. Okay, we went to the surgery, and this is the surgery. It's very similar to the case I showed before, and we perform our vitrectomy. We stain with brilliant blue. As I repeat, I don't use fluocinolone to stain. Stain is not a good word for this, but to stain the posterior hyaloid. We start with the posterior hyaloid. This is a new forceps. I was testing this new forceps. I didn't like it too much, but I began with this, removing first the posterior hyaloid again. And after this, we re-stain to find the internal limiting membrane. At the end, we remove the internal limiting membrane. We create the inverted flap, superior flap to the inferior retina. As you can see here, don't press down, don't put the flap inside the hole, just a little bit, to the inferior side. Then you aspirate in the inferior part of the retina, as you can see here. And the day after the aspect is this, and this is a very good aspect. I do OCT the day after in all of my cases. And as you can see here, you can see the ILM there with the reflex of the gas in here. But the aspect was good. 3 weeks after the surgery, the gas had disappeared. The patient came to me and told me visual acuity was very poor. It was around 2200, and she was telling me, I have central scotoma. I cannot see your face. I cannot read with this eye. And look at this, the OCT, the Macular hole was closed, but these bumpy areas over the RPE. Perhaps you're thinking about subretinal membrane, but this is not typical subretinal membrane. You can see many bumpy areas here over the RPE. And the patient said, my vision is very poor and my vision is worse than before. And perhaps you are asking me to show you an OCTA. The OCTA said nothing. There were no choroidal neovascularization in this case. Let me show you the autofluorescence in this case. This is a terrible, this was not before. This is a terrible RP lesion, both in the posterior retina and the anterior retina. Of course, you are thinking about why did it happen? And perhaps you're thinking toxic phenomenon. But this is brilliant blue. This is the same brilliant blue I always use. There are many papers saying that brilliant blue is not toxic. And the surgery was normal, it takes 30 minutes around to do all the surgery. Perhaps you think about phototoxicity, but remember here is the place where there is the entrance of the light. And you point down to the peripheral retina, then I think it's not possible to have phototoxicity. I always show this case in the meetings when I speak about macro holes in high myopia, because I'm trying to know why this patient developed this, because the other eye is high myop. Then the other eye may show the same problem in the future. Only one surgeon in the world, my friend from India, from Delhi, that I'm sure of, showed me a case that, it's not the same, but he had the same problem in a patient that he used brilliant blue from the same trademark. And look at this, he showed this bumpy, aspect over the RP. But, the aspect of these RP lesions are not the same. They respect the vessels, as you can see here. And, I don't think it's the same, but, if you have any case, please show me the case, because I'm trying to know why it happened to my patient. Look at this. This is a comparison of the two cases. I think the distribution of the RP is really different, and I don't think it's any relationship, but if you have any case, yes, show me. In the third case, and the last thing I want to share with you is this. As a surgeon, we use these devices to control, edema, or trying to increase the pressure. But in some cases with silicone happen this. This is a case of, there was a PVR. This is the aspect after the surgery, after retinotomy. I injected Ozurdex in the cavity, and the Ozurdex went over the retina. You don't want the Ozurdex to be there. Or in some cases with a very bad diaphragm, you can have these devices in the anterior chamber. And in the anterior chamber, you can have the problem of corneal edema, discompensation, etc. My advice, if you have to use Ozurdex or Iluvien, because in some cases we use Iluvien, in very bad cases, off-label, of course. We described in 2014, we describe how to, in these kind of difficult cases, to suture the Ozurdex to describe. Very recently, this is in 2020, has been described the same technique. 1 year ago, we had a case. We have done this 3 times with Iluvien. Let me show you the first case was 1 year ago, in a case of coming from PVR, was aphakic, was silicone oil, a hypotenuse eye. We tried to recover and to increase the pressure in the eye. Then, and then we did this. This is very simple to do. This is a 23 gauge knife, and then we remove the Iluvien from the injector, and then we use this suture to make a knot, and we put inside this. You have to be very careful because you can break it, right? Then we put it inside, and then we put it totally inside, and then we put the conjunctiva over this. And that's everything. That's all that I want to share with you. And I'm trying to leave.
Thank you very much, Dr. Carlos. On time. If there is any question from dear colleagues here, Dr. Saad, Dr. Carlos Belgizio, or Ahmed, to Dr. Carlos, or any comments?
I just have one question, Carlos. Just your last case,
sure,
that you're showing the suture, the Iluvien.
Sure.
Do you push it all the way into the eye? So it's going to be fixated only at scleral level? How do you do that?
I put it just to the sclera, you know, in the sclera, I put the suture over the sclera, but it remains in the, you know, it remains attached in the tunnel of the sclera. Then perhaps you think, okay, you have less dosage inside the eye, but I do it like this.
So the reason why I'm asking you that, Carlos, is a very specific reason for that. The implant only releases the drug from one end.
Yeah.
So you have to be sure that you're putting the
open
end first.
Yeah. Yeah. We put the
one to release the drug. Second, that you don't want to damage it. So that's an important thing for the others to consider. You have to put it in the right position, otherwise it doesn't work.
You're absolutely right. And then sometimes we put the implant through the canvas, not suture. We put inside the trocars, and then we remove the cannulus, and then we leave it in the sclera. But as you mentioned, it's very important to put it, you know, with the end, the correct end, not in.
Is there any sign for the anterior or posterior side of the illuvian? So you can judge this is the area.
We remove it from the syringe, then we grasp it, and then we put it in the correct position as it enters in the
I mean, if it is moved in your hand, there will be no way to see which one is the side of releasing.
No.
But Fabrizio, you have an experience.
Yeah. Remember, the bit of the illuvian that will release the drug is the trailing end from the injector. So the bit that is going first is the dead end.
The end,
right? So if you're going to remove from the cartridge to be used that way, you have to turn it around. You have to reverse the order, because otherwise you get the wrong end. So normally when you inject, the bit that goes first is the dead end. The release end is the trailing end.
Exactly.
So when you remove it from the cartridge, you have to turn it.
No, I mean, if in case it's there in your hand, there is any sign to know which is no.
I'll tell you, I haven't tried to do that, so I don't know visually if I would be able
any
to.
other comments? Okay, is there any question?
I need just to ask, thank you, Carlos, it's very interesting cases. I'm excited to know the result of the last case, what's happened after you put the illuvian in such interesting way.
You know, in this when we use illuvian in these kind of cases, these are cases that we are trying to increase intraocular pressure and to decrease the retinal edema. I have to tell you, I have done 3 times, and only one case increased 5 millimeters of mercury in intraocular pressure. I think intraocular pressure is for me, is my worst problem in severe cases, PVR, and you know, in these cases that you have 1, 2, 3 millimeters of mercury.
One more point. Oh, sorry. Go ahead, Dr.
No, go ahead. It's fine.
Yeah, I'm just asking about the, you know, we all know that the macular hole and posterior staphyloma with myopic, it's a challenging case, you know, and you presented very nicely. And I know that one of the tricks that you have to peel the ILM until the edge of the staphyloma to avoid that. And one of the most challenging, one of the most common reason that, because for sure you position in the patient post-operatively, right? Because you need to have a gas bubble to fill all the staphyloma space. Do you think that suturing the sclerotomy, it will make sure that you are going home, you know, you are feeling that there is no, because if you have any leak on the first post-operative days, the pressure of the gas inside the eye, it will be soft, and then you might, especially are using 23 gauge, or you don't have this kind of point in your mind while you're dealing with it.
Very good question. Look at this, in the staphyloma, when you are doing these cases, you have 2 objectives. This is different to idiopathic macular holes. Idiopathic macular holes, you want to release the traction around the hole. This is no problem. Okay, in this case, it's different. You are trying to increase the retinal elasticity. Remember that the ILM is the most tough of the retina, more rigid part of the retina among the vessels, you know, the arcades. But, you know, in this case, I go around to the border, to the edge of the subflora, trying to increase as much as possible, you know, the retinal elasticity. This is first answer. The second is the gas I use is SF6 20%. SF6 20%, in my experience, is a little bit expansive. But you know, at the end, I do something, especially in the sclerotomies, and if I feel that, you know, the eye remains stable, I don't suture, but in many cases, I suture to be sure that, you know, the eye, the day after, will have more than 3/4 part of the vitreous cavity full of gas. Because some surgeons in idiopathic macular cases say, okay, I only use air. Okay, air is perfect, but you have to have, you know, the eye full of air.
Okay, thank you, Ahmed, because we are having, you know, we are running behind the time, and we have many of our dear friends. They are attendees, and they are a well-known international speaker, and they want to ask a question. I will give two for this time. I have Dr. Nicola Ghazi. Dr. Nicola, we are happy that you are with us. Can you open the mic for Dr. Nicola to give his question?
Yeah, thank you. Thank you very much. Very interesting presentations. Can you hear me?
Yeah, we are hearing you, Dr. Nicola. Yes, go ahead.
Yeah, thank you very much. I appreciate it. Hello to all the dear friends and colleagues. I hope you are all safe and fine. I just wanted to comment on the, thank you. I just wanted to comment on the illuvian suturing to the sclera. No, I've seen a different technique than the one that Carlos described. And I kind of like it because you don't have to worry about which end is inside the eye. This technique actually sutures the illuvian circumferentially in the pars plana. So after the illuvian goes all the way in, actually the illuvian implant is sutured outside the eye, a slip knot is put around it, then the implant is thrown inside the eye, and then it's sutured just like we suture a haptic to the edges of the scleral wound, and it lies flat on the pars plana internally. There's no part of it that stays outside. And I was wondering if Carlos has an experience with this or any of the speakers.
No, but this is a good idea. I think it's a perfect idea, and you know, this avoids the problem that Carlos mentioned, to have too much. And in many cases, you don't see at the end. You suture the sclera over the implant, you don't see anything. But you know, this is a concern that, you know, I agree with Carlos that may be a problem. But you know, suturing for these kind of cases, we are talking about severe retinal, you know, vitreoretinal problems. You know, this is not about uveitis. This is a big problem for severe cases. I think it may help some of them, traumatic cases, for example, trying to increase the intraocular pressure. Although, you know, the main reason of hypotony perhaps is not inflammation. But you know, in some cases, may help to increase the pressure.
Thank you, Dr. Carlos. Dr. Nicola, thank you very much for your.
Thank you very much. Thank you, Dr. Amri.
Anyway, Dr. Nicola is all the times he's having a good, I mean, all innovations for something regarding vitreoretinal, well-known figures in the Middle East and vitreoretinal. Thanks for sharing with us your experience. I will have now Dr. Saad his question. Then I will have also another question from one of attendees. Dr. Saad, if you want to comment or to do.
No, it was just great cases from both Ahmed and Carlos. I was just wondering what type of suture you would use when you're suturing these implants.
It's Prolene.
Prolene, okay.
Yeah.
Okay, so can we have Dr. Safwan Bayati for a question from live, please, Dr. Safwan.
Hi, Dr. Muhammad.
Hello, Dr. Safwan. Most welcome, dear friends. Please.
I just need to thank Dr. Muhammad first and the old speakers for a very nice presentation, especially Dr. Ahmed and all of them, really all of them. I enjoyed all the presentation, but I need to thank Dr. Carlos for a very important point that he highlighted related to the trepanning blue. Now, a few points, because I do agree with you, Dr. Carlos, that in few cases that when we are using the trepanning blue once and twice and 3 times in the same case to to highlight especially a very thin, delicate, especially in high myope with the posterior staphylomenon. So I had also the same cases that one of them presented to me with the same RPE changes. And definitely at that time, when you ask yourself what's happened, I asked myself the same issues, but it's very clear. There's two issues, the trypan blue and phototoxicity. I don't think so that phototoxicity can ever create such a changes in trypan blue, in RPE. So mostly it's a trypan blue. I don't know whether you have any solution in your mind, any options to change, return back to the ICG or any other material that will be safer than trypan blue?
Let me tell you, I don't use trypan blue. I abandoned trypan blue. This is brilliant blue. This is not trypan blue. I never use trypan blue.
That's what I'm saying. Yeah. You are taking it from which company?
It was Zork. It was Zork. Yeah, it was Zork. And the case from India was Zork. But I'm not sure that this is. The thing I think is perhaps a personal, relation with the dye. The characteristics of the patient, of the RPE. But I haven't seen with brilliant blue. If you look at the literature, you won't find any paper that says that to the RPE toxic.
Okay.
Right, you are right. Because
thank you very much. We can go ahead, please. We have only one more question. Dr. Jamal Al-Kandari, please. Can we have Dr. Jamal? Dr. Jamal Al-Kandari, a vitreoretinal surgeon, dear friends from Al-Kuwait. If you have a comment, are you there, Dr. Jamal? Can you open the mic for Dr. Jamal, please?
Yes, I'm waiting for him.
Dr. Jamal, can you open your mic from your side? Okay, if not, so we can keep to the end. Now I want to introduce my dear friend. Okay, you find him? If you find him before we introduce Dr. Saad, it will be great. Okay, can you close any others, please? Close the mic for others, except our speakers. Okay. So now we will have Dr. Saad Wahib, is my dear friend, and he is a consultant ophthalmologist, associated professor of ophthalmology, King Abdulaziz University College of Medicine, head section of ophthalmology, King Faisal Specialist Hospital and Research Center in Saudi Arabia. Please, Dr. Fahad, go ahead, share your slide and start. Thank you.
Thanks. Thank you very much. Thank you, Muhammad. It's always a pleasure to be with you. I'm just going to, for the sake of time, go with my cases. I've got 2 or 3 cases which are a combination of medical and surgical retina. This was a 70-year-old, usual diabetic. As Ahmed was saying, most of our patients, unfortunately, are fully controlled. She came in to see us with decreased vision in both eyes. She's pseudophakic, and she was not comfortable with the idea of having monthly injection. After trying to convince her, she got 2 anti-VEGF. We used Eylea in this case, and the vision did, you can see the edema in both eyes, more so in the left eye. With the anti-VEGF Eylea injection, aflibercept, she improved in the right eye, but she did not show major improvement in the left eye. And at that stage, I discussed with her, if she is not willing to come monthly, the possibility of steroid implant, and we decided to go ahead and use Dex implant in both eyes. You can also see, looking at the OCTs in both eyes, the usual OCT biomarkers of inflammation in the form of subretinal fluid, the hyperrefractile dots, and the cystoid changes. The right eye actually did very well, and the vision did improve, but the left eye, this is just a technical point. As Ahmed was saying, when you're injecting dexamethasone, you want to, just like when you insert the trocars during the vitrectomy, you stay at an angle first, and that's very important. and that is different from Elevine, as you'll see in a second. And I routinely inspect these patients after injection. So as I said, her right eye did show an improvement, was very stable, but the left eye recurred after 4 months. Her IOP, which I usually check in the 2nd month or after, even in the middle of the 2nd month, remained very stable. And she was still not comfortable with the concept of using anti-VEGF monthly injections. We decided that we're going for Dex, for the 2nd Dex to the left eye, but for a reason she traveled abroad, I think for knee surgeries, and she received the Elevine implant. She came in to see me after almost a year after the Elevine, and she looked actually pretty well. She's the macular edema, her right eye remains stable, but the left eye, this is her left eye, which has shown a definite improvement with improvement of their visual acuity. And at that stage, I consulted her on using combination therapy and injecting her with anti-VEGF twice, and she's done well. She came last week to see me. It was very interesting because I had her almost 3-year pictures, and she looked pretty well actually, and that gives us an idea of the stability of the Elevine implant in these inflammatory cases, whereby you can see the improvement both anatomically and functionally. And again, just a technical point here, when you're injecting Elevine, you can see that you want to be perpendicular, whereas in Dex, you come at an angle, and I think that's probably an important technical point. Things I want to, the take-home message from this is that I think we're not switching early, and I think switching early is very important in these patients. If you keep on injecting anti-VEGF, I know in this patient this was a compliance issue, but I've seen people who've continued injecting anti-VEGF for 6 or 12 or sometimes more than that. I think you ultimately get thinning of the retina, but the vision is lost. So I think switching early is important for the functional improvement that we want to get. Combination therapy is important. I was really impressed with the results that Dr. Ahmed presented, because in my experience and internationally, the Elevine implant would require at least 6 to 8 weeks to show an improvement, and sometimes during the course you might have to use top-up either in the form of Dex or even anti-VEGF. This is what I'm saying here. The second case, I'm just going to move into the second case, was a 42-year-old female, nice, educated. She's pregnant in her 2nd trimester. This was a very precious pregnancy. She came in with blurred vision in her left eye for a few weeks. She's non-hypertensive, under control. Her visual acuity was 20/20, 2100 in the other eye, with very mild hyperopic astigmatism, normal IOP, normal anterior segment. Her fundus examination, including the optos, looked initially pretty okay. Her OCT showed classically the macular edema with classic subretinal fluid and cystoid changes. When I went back to look into her carefully into her left fundus exam, I could see like an old vein occlusion, which is probably resulted in this. After consulting with the patient because of her pregnancy, I was worried. In using anti-VEGF, we agreed to use dexamethasone, which is done pretty well. And it's my experience, and I don't know about what the panelists think, but these patients, the vein occlusion patients, respond very well to the steroid implant. Of course, we agreed that after delivery, she might go back and use anti-VEGF. I think I just wanted to stress the importance of the OCT biomarkers. You want to look at them. We're considering now naive patients sometimes. You want to look at these serous retinal detachments, the presence of hyperreflective dots and cystoid changes, which are all suggestive of the fact that these patients might not be good responders to anti-VEGF. And all the studies, whether it's the real life studies or the randomized trials, have shown that you have approximately 1/3 of patients who will not respond well to your anti-VEGF, and I think you should keep steroids at the back of your mind, and I think switching early is a key. I'll take you into a third case, which is more of a surgical case. This was a 50-year-old gentleman who comes to see me, referred after having 8 anti-VEGF injections with not major improvement of his macular edema. and he's also had some evidence of PDR. So we agreed that we're going to treat this with surgery, and I think surgery is an option that should be kept at the back of your mind. And we need to understand that some patients are tractional, so no matter how much injections you give them, you ultimately need to go for surgery. I'll show you quickly the procedure. I decided to keep the lens, and I routinely in these patients, this was just a cord vitrectomy. You can see the tractional component on the macula. I routinely use triamcinolone. I know Dr. Carlos does not like to use them, but I find them very useful, specifically in diabetics. They show you the vitreous. There's a lot of vitreous cases. You can see here, I'm trying to induce PVD. You want to be slow. You want to take your time. You allow some hydration. And then slowly, you can see a little bit of bleeding that is usually managed well with increasing the intraocular pressure, and ultimately you will do the PVD. And then after that, I leave a little bit of this triamcinolone as an anti-inflammatory, so it truly helps, especially in these diabetics. They always have these vitreous cases. A little bit of endo laser also, and then I do air fluid exchange, and I leave them with air. Just a few tips, practical tips for inducing PVD. We know that PVD in diabetics is somewhat a difficulty. I think visualization is very important when you're inducing PVD. You want to make sure you're seeing everything very carefully. You would like to start at the edge of the disc and you move up. And this is one of the mistakes that we see with some of the junior staff or the new coming fellows. They tend to pull towards the sclerotomy. You want to move up. And you would like to be patient, give some time for hydration, and then you will see that it will come slowly. And I think everybody is going into smaller gauge, and it definitely going into smaller gauge means that you're going to get closer to the retina, but I think you would like to be careful because smaller gauge does not mean smaller problem. And if there is a retinal attachment, in these cases, sometimes you have either combined tractional, retinogenous, or tractional, you always want to start facing the attached retina. So going back to the patient, she initially showed reasonable improvement. Within 2 months, his vision improved, still had some evidence of macular edema. And at that stage, because he's phakic, we decided that we're going to use anti-VEGF. I used, again, aflibercept. And after 2 injections, the macular edema kept on fluctuating. And then I told him that, you've got a little bit of cataract. There's a good chance that we're going for surgery. So we decided that we're going to Ozurdex after discussing the possibility of surgery. The IEP remained normal, and he responded actually very well, and his vision is improved. Now, one of the points that I wanted to raise is that these patients, after vitrectomy, the half-life of anti-VEGF is much reduced, so the effect is going to wear much faster, and thereafter, the concept of long-acting depot medications like Ozurdex is definitely important. And this brings us to this point of the mean retinal thickness amplitude, which is an interesting point that has been brought up, which I think Dr. Carlos in his first, and also Dr. Ahmed alluded into it. You see, when you treat these patients, the fluctuation that happens in retinal thickness is somehow somewhat damaging each time. The retina, the macula, like a sponge, swells and decompresses, you get some damage. And I think the mean changes that you see with the 11 implant is definitely less. And in a study that showed that the changes prior to the insertion of the implant was around 230 micron, while with the implant is 96 micron. So we would like to have a stable control, which definitely is achievable with the 11 implant. I think that takes me to the end. This is nobody is in the corniche, and hopefully once we get this COVID-19 problem over, we will go back and enjoy it. And I hope everybody stays safe, and inshallah we will get over this. Thank you very much.
Thank you very much, Dr. Saad. It's for this very interesting cases, and at the same time on a time properly. Thanks a lot. Can you just do a slide?
Sure.
Yeah.
Stop sharing.
Stop sharing. Yeah, please. So we can have, if there is any question from dear friends here available to Dr. Saad about his cases, presentation, or whatever, then we are having many questions from many dear friends live, and we will start prepare Dr. Madaf Rao. to talk with us, but after any question from the dear here friends. Dr. Bavizio, if Dr. Carlos, Dr. Ahmed, any comments? Can you just please remove the mute? You are mute, Dr. Carlos, Bavizio, and Matthew. Okay. So any question to Dr. Saad, any comments?
This one thing in the surgical point of view, okay? When you mention how you remove the posterior hyaloid, for me, this is one problem. Let me tell you, the new vessels on the optic disc. Because if you remove the posterior hyaloid and the new vessel of the optic disc, then you cannot apply diathermy. You can increase the pressure, but many of these cases, the day after, they have vitreous hemorrhage. Then the thing I do always is trying to preserve. If there are big vessels in the optic disc, as you mentioned, I remove the posterior hyaloid and I leave there a piece of tissue just to put diathermy. Diathermy is not very profound effect. It's very superficial. Then you can do this, this diathermy in the vessels of the optic disc, trying not to affect the optic disc, of course, but leaving some tissue in the optic disc, trying to avoid the day after a vitreous hemorrhage. Perhaps you leave gas, but at the end you leave gas, but the gas is disappearing and you have more blood. Then the patient, 3 weeks, 4 weeks with recurrent vitreous hemorrhage. Then in these cases, I try always, my advice always, the mistakes I make every year and every time is trying to remove this to have a perfect picture of the patient without any new vessel. Then I always try to leave an island of tissue around the optic disc. I remove the ILM just to avoid the contraction of this tissue to drag the fovea. But I think leaving some tissue around the traction is good for diathermy and to avoid postoperative vitreous hemorrhage.
Sure. I could not agree more. Yeah, I could not agree more. And I think what we usually do, definitely sometimes you would pre-treat these patients with anti-VEGF a couple of days before surgery. And definitely, as I said, visualization is important. If you see a vessel, you think it might bleed, definitely you'd like to use endodiathermy or sometimes even endolaser, but you want to be careful, and I truly agree with this. Thank you.
Thank you. Okay, thank you, Dr. Carlos. Because we are having, can you, John, please open the mic for Dr. Madaf is available. At the same time, meanwhile, I want just to apologize for not to give my talk because I'm not lucky today to give this talk in presence of these eminent speakers, but maybe in the future, maybe I have a chance to do that, and this because of the sake of the time. Yes, Dr. Madaf, yes, can you go ahead, please?
Good evening, Dr. Mohammed, and good evening, rest of the speakers, and Dr. Carlos Matthew. My question was to Dr. Carlos Matthew. I think he was trying to answer my question. This is regards to our first case, which he showed of a myopic tractional maculopathy. My question was, is there any classification and staging of myopic tractional maculopathy followed? And if so, does it really help? I mean, in deciding which patient should be taken up for macular buckle and second for vitreous surgery?
Okay, I answer in the chat, but I have 3 cases. One is schisis. And in the schisis, you have 3 versions. You have progressive schisis. These are patients that they don't have, foveal detachment or inner defects in the fovea. This is a progressive. So these patients, normally they don't have lost vision. They can have good vision for, many years, but, they start to lose vision with foveal detachment. And then if they show, then I call this foveal detachment. And the third is when they have this, foveal inner defect. That for me, there are 3 different cases. I don't try to say, okay, tangential traction, anteroposterior traction, because, this is only one cut. You don't have the whole image of the old macula. There are many tractions. There is the ILM, there are the vessels, so many tractions in the myopia. Depends on the type of the staphyloma. The second thing is to classify the macular holes in 2. Macular hole without schisis, I show you 2 cases, and macular hole with schisis. I see every 1 case of macular hole with schisis, I operate 30 cases of macular hole with schisis. Then the macular hole without schisis are more frequent seen than macular hole with schisis. And the third problem in these high myopes is macular hole retinal detachment. This is for me the classification. Trying to find, you know, a classification of the traction and all of this stuff for me is so difficult because every myope is different. You make an OCT and you see one traction from there, one traction from here, you know, it's so difficult. Then for me, these are the three main cases. About the macular buckles, now, you know, I only use macular buckles for cases where they have retinal detachment related to a macular hole with a profound, with very steep, you know, posterior staphyloma. Because you can ask me why I started in 2004 and now in 2020, I changed. I changed because we learned a lot in the surgery. We learned how to distinguish between the posterior hyaloid and the ILM. We improve our visualization during the surgery. Then all of these improvements have made that, you know, the anatomical prognosis have improved. But, you know, functional prognosis in high myopes is difficult. It's not in, we haven't improved that much.
Thank you, Dr. Carlos. Because of sake of time, we need only a very short as possible the answer. I know there is, you can go the long. Thank you for your information. We are having, can you open the mic for the Dr. Mamata Mital? Meanwhile, I have one question for Dr. Ahmed. Dr. Ahmed, I think your case with unilateral macular edema she is young and classically she is a case of Paget disease, or you have to rule, or do you have to rule out infection like TB or syphilis? We have many cases like that. Any comment?
Okay. Yeah. Thank you so much. I believe if you look at the, I didn't show the fluorescein angiography of the other eye, but the other eye was also, there was a macular aneurysm. And if you look at the FFA, it was a leaking macular, typical case, no vasculitis, no vitreous haze. Also, the patient is almost 55, I think, years old. And for me, there is no signs of uveitis in this case. It was a straightforward case, the case of the DME, because the fluorescein angiography showed that there is no signs of VESIT or TB, and there is no signs or symptoms of flare or EC cells or something like that. So I don't think so. It's a case of uveitis, but it's a good point to consider. Maybe yes, I agree that some cases may mimic the situation, but in my case, I believe it. I also I'm very happy to hear other comments from my colleagues if they have any other thoughts, especially Dr. Carlos from UK. From Carlos UK is uveitis, so he might have an sort of input about this.
Okay, this is question actually to Dr. Carlos Pavizio. When would you repeat ILUVIEN injection once you see the edema is recurring after 1 year, or you would give Ozurdex, I think, the top up, or you would go for ILUVIEN, or you have to wait 3 years? This is my clarification.
I think for you to propose a new intervention will be dictated by the clinical response. So if you're seeing recurrence of the edema after 1 year, so it means that your intervention is not working as you expected. So the duration of the intervention is not working. So the options are either because there is an issue with activity of the disease for which the ILUVIEN is not sufficient. So you need to give this patient a top-up with the hope that this will settle down again and the ILUVIEN can continue the control. So one alternative you have in this case is I wouldn't give another ILUVIEN in this case, but I would maybe give a Ozurdex on top of the ILUVIEN to induce control of that event, and then see what happens when you pull back. Remember in the trial data I showed you, there were recurrences in the 36 months, but when you look at the group treated with the implant, most patients had one event, sometimes two events, throughout the 36 months. So a rescue for that event at 1 year may very well induce control and allow the implant to work for the rest of the time. So it's worthwhile exploring a rescue therapy, as you would say, for the trial, in using an Ozurdex, and then see what happens after the Ozurdex expires.
Okay, this is a question from my side actually. What is the, when do you think for top up? What is the time? Do you have, from your experience, after how many months you will start thinking of top-up?
Well, no, I think it's not the top-up that I mentioned now. It would depend on the recurrence being clinically visible. So you give an implant. If there is no response, that's a different story. If there's zero response, then there is a problem there, which may be that disease, that condition is not responsive. But if you see a response and then you see failure, that's when I go for a top-up.
Okay. So do you think, whenever you start to see, for example, if we give Illuvian and still we have only, and there is an improvement within 1 month or 2 months, then one of a sudden you saw after the 3rd month, for example, there is a deterioration. You will give a top-up even after 3 months, or you have to wait again to after maybe 2 months, maybe to see more results? Or
no, if you, let's say you see some of the examples I showed, the patients may respond depending on the nature of the problem. The response may be faster or a bit slower. Some patients respond very quickly, so within a few weeks you can see the benefit of the implant. In other patients, it may take a few more weeks. The point is, if you see a response, if you see the benefit, and then you have a escape of control, no matter how long after the implant, you may rescue that patient with whatever strategy you want, either local or systemic, and then see what happens once you bring it under control again. So the real issue is lack of response to the first injection. If there's no response, then it may very well be that it's not going to work. Then you may have to abandon that strategy and use your regular strategies. But sometimes one injection or another treatment to bring it down and see what happens may be worthwhile. I have seen very few failures, primary failures. I've seen probably only 1 or 2 patients who have not responded, in which case I had to reconsider what I do and decide case by case.
Okay. One question, but a very fast answer, please. Could you please give us a sign of indicating inflammation in clinical macular edema? Significant macular edema.
Who's that question for?
For you, please.
Oh, for me. So what is it? Please repeat that. It's
there is, what is the sign indicating inflammation?
Well, meaning in general terms, inflammation, posterior segment inflammation.
Most probably in diabetic macular edema.
Okay, well, the macular edema in inflammation has several different behaviors. If you look at angiographically and OCT, you can have a more cystoid, but even many times have very diffuse edema. The presence of subretinal fluid in these patients has not the same impact or the same meaning that you have in diabetic macular edema, in which you clearly said it is a sign of a more aggressive disease, or prognostically different for the anti-VEGF. In uveitis, it doesn't mean that. Subretinal fluid in the subfoveal location just means treat the edema as you would normally treat. So not many times edema can occur because you're having vasculitis, or sometimes because you have a vasculitis involving the posterior pole, or because you're having more diffuse vasculitis, or even a anterior uveitis, which is going on for a long time, can generate macular edema. And those tend to be more localized than the others that are more diffuse.
Can we have now a live question? There is Dr. Mamata Nital. Can you find it? If not, please go to Ahmed Khalaf, please. Mr. Owen. Okay, Dr. Ahmed. Can you open the mic, Dr. Ahmed, and start, please? After Dr. Ahmed, we are having Dr. Carter. Please, can you make ready after Dr. Ahmed? Dr. Ahmed. Okay, Dr. Ahmed Khalaf, can you open the mic, please?
I already posted my question in the written one, so thanks a lot.
Okay, thank you, Dr. Ahmed. Okay, can you have Dr. Carter, please?
Dr. Muhammad, just to clarify,
yes,
when you ask Dr. Carlos about the top-up, you was meaning top-up in uveitis or top-up in DME, or?
No, in DME. I was talking about DME.
Ah, okay.
Oh, sorry. So I got it. Uveitis. My response was uveitis based, not DME.
No, we are thinking that's maybe Ahmed, you concentrate more than me. I'm concentrating. Okay. You have any comment on DME more? Carter, Dr. Carter, can you start? We are hearing if you are there. Shabra, Dr. Carter Shabra. Okay, if not, can we go to the next, please, Mr. Wayne, Stingo, Titana. Okay, Carlos, can you give us answer this question meanwhile, because Dr. Carlos, like one proposed in Italy, especially by Dr. Barbara Barolini, vertical or perpendicular traction or tangential traction. This for Carlos Macha. Can you comment on that?
You know, as I mentioned before, for me, it's I answered before. For me, trying to classify the traction for me has no any utility. Has no any for me. Barbara is a good friend and she does it perfect. But you know,
a different school, different approach.
Well, you know,
okay.
Yeah, perhaps it's this, but you know. He's trying to put doors in the heaven, you know, he tried to compare all myopes and, you know, so they are so different. The type of the staphyloma, the deepness of the staphyloma, you know, it's very difficult for me, you know, to follow these many different groups.
Can you open the mic for her, please? Okay. Anyway, can we have also Dr. Ahmed Barti? We have one question of you. With your last case, do you think to do a focal laser photocoagulation under fluorescein angiography, or to try retinal micropulse laser by Navilas?
Yeah, that's a good point. Talking about laser, actually, I think most of us agreed now the result of laser and the macula and diabetic does not have any. I mean, the result is very poor compared to the pharmacotherapy, generally speaking. About micropulse, sorry, I think I don't have any experience. We need, I think, more data to prove that. Is it improving the vision or not? And also, if you do a focal laser in this case, it's they told you it's very close to the fovea, so foveal vascular zone. So I don't think that will help. But for micropulse, I don't have experience.
Okay, thank you, Dr. Ahmed. Just to remind dear colleagues here who they are listening to us, there will be a survey. Please, you have to answer this to fill up the survey and send back. So according to that survey, they will send for you the CME accreditation. This question: any indication of anti-VEGF in SLE? Any comment? I think this Carlos Pagizio. SLE is it?
Sorry, can you? I'm having trouble with the audio. Can you repeat the question, please?
Any indication of anti-VEGF in SLE?
SLE.
Systemic lupus erythematosus.
No, well, SLE is a microvasculopathy. It's not truly an inflammatory problem when you see the back of the eye involved. It's mainly vascular occlusion. So what you see mainly are cotton spots. You don't tend to see a proper inflammatory event. So I don't think that the management of SLE will be a systemic management. It means if you see the changes in the back of the eye, it's because the systemic disease is misbehaving and the treatment is systemic to prevent the damage to the eye.
Another question: usually ILUVIEN effect lasts for 2 to 3 years according to the study. One of the patients developed macular edema after 7 months. Is it common? Kindly comment. I think we talk about this one, but
yes. Yeah, I think we are seeing a spectrum of behaviors. We are seeing the patients who are going the distance, they're fulfilling the 3 years. We are seeing patients who are having shorter duration of the effect, but it's less common to see failures early on. I think this few months not working is uncommon. Let's put it that way.
Another question also: have you seen any time when Ozurdex was effective, but no change with ILUVIEN implant, and so patient was again shifted to Ozurdex? I think they are here talking about shift, not to top up.
Okay, well, the one thing I've mentioned many times when discussing with people is that I find Ozurdex is a more powerful drug in the point of view of the more acute impact. It works faster, it's probably more potent. Maybe the Alimera people I've spoken to don't necessarily agree with that, but I tend to see a more powerful effect of Ozurdex early on. So it does mean that potentially some diseases need a higher dose for a certain time to get control. So there are situations in which maybe the Ozurdex will be very good and the Iluvien may not fulfill the same impact. And that is a possibility in some cases. So it's not always predictable that someone who responds to Ozurdex will necessarily always respond to Iluvien.
Do we have Dr. Saad Wahib here with us? Dr. Still Saad, we are with us.
Yes, I'm here.
Dr. Saad, there is a question. Do you have, the question we asked before, the sign of inflammation on OCT due to diabetic macular edema?
Yeah, I think this has been looked before and has been, I think, illustrated as I've shown. There are certain signs that you can see even sometimes from the beginning. You can see these changes that are on OCT, like the presence of subretinal fluid, the HRF, the hyperrefractile dots, and the cystoid changes. I think they all suggest the presence of inflammation. Now, this does not necessarily mean that you would start with steroids, but definitely you will have a lower threshold for keeping these patients on anti-VEGF or for switching into steroids.
Okay. We have one question for anyone who wants to answer. Any systemic affection of intravitreal steroid in diabetic patients? So when we are giving dexamethasone or Iluvien, is there any effect?
No issues. There's no concern about systemic. The drug will be detected in the blood, but it's a very small amount, nothing to impact systemic.
Any other opinion? It's the same for Dr. Saad, Dr. Ahmad, okay?
Yeah, I think there is no, even the study showed that.
One? Okay, because I see this several times, so I want to assure them that there is no effect or systemic effect. Last question, when will you say that Iluvien is not responding or there is no response for Iluvien?
I think the experience is showing that normally you will get a response within the first few weeks that you implant it in the eye. It all depends on where you start. If we start with a pathology which is minor problem, then you might see an impact earlier. If you see someone with an edema, which is a very prominent edema, it may take time for that to respond. And I have examples of patients that I injected one eye with Iluvien, the other eye with Ozurdex, and the edema goes very quickly in the eye than the Ozurdex, and it takes longer to go away with the Iluvien. So I wouldn't give up in the sense of concluding that it's not working if after a month you see a small impact on the edema. That is important to see something. If you see nothing, it's worrying. But if you see a small reduction, just wait, because the likelihood is that we'll continue to improve.
There is a peak, can you say there is a peak for response about this one? Can you say, for example, after 3 months, because we have last time discussed this one, I think Dr. Saad will discuss as well with us in the last meeting, or I don't know, and they are saying that usually, or Dr. I think Abdullah Al-Qahtani, my dear friends, they are talking about 3 to 4 months or up to 6 months. There will be a slow, but maybe you will start see the peak in the in 6 months.
Is that for diabetes or inflammation?
Yeah, that's my question.
Macular edema, only diabetic macular edema.
Okay, because it depends on the nature of the edema, the response will be different. So in inflammatory cases, you're likely to experience a more rapid improvement. In diabetic edema, it may take longer to show a response. So,
I agree. And I think probably
yes, Ahmad.
Sorry, Dr. Saad, you can go ahead.
No. I was just adding. I think there's also a difference in the amount released. I think Ozurdex releases a little bit more, so that's why you see the response faster and much more quicker. And I think that's something that you need to know. You will probably see a quicker response with Ozurdex, but a delayed, more sustained response with the Iluvien.
Yeah, if I can have a comment on this, because as I show you in one of the cases, sometimes the response is very fast, 2 weeks or 4 weeks, you have 5, but sometimes it's delayed. But my point is, don't rush to top up, because the reason you switch to steroids, generally speaking, that you don't have maximum response from the anti-VEGF. So let's give an example. If you have a patient with 500 micron edema or macular edema, and you keep injecting with anti-VEGF, and the maximum reduction in thickness was like 300 thickness. So it's still edema there. So you decide to switch to steroid or Iluvien, whatever. And so as long as the edema does not go back to 500 or 600, it's playing around 300, 350. That means that this drug is still working. So give a chance for the drug as much as you can. For me, I'm not rushing to top up, because the reason I'm switching to steroid, I don't have a good response or enough response from the anti-VEGF. So I should keep watching those patients as long as the edema does not increase. So I'm doing my target. My target is achieving now by maintaining the thickness on this level. And by time, for many cases, you can see that this edema start to resolve, or it might increase, because you know what, during the diabetes, the level of the control, the other comorbidities, not every patient is the same, because we have a lot of comorbidity which can affect or delay the response. Also the release. If you have dictomatized eye, thick vitreous, something like that, it will affect the bioavailability of the drug and the release of the drug. So there are many factors. So the message here, as long as you don't have worsening of the case, stay and wait and keep an eye on this patient, because they might improve.
Thank you, Ahmad.
That's my point.
This clarification. I think we'll give this. We see if we continue waiting, then more questions coming. I want to finish.
But Dr. Mohammed, I need answer to my question at the last of my presentation. I have a question for the panelist.
Okay, let me.
I need to know their experience.
Any OCT thickness measurement guidelines for using Ozurdex or Iluvien and Iluvien? I don't think so.
I think you had asked about the biomarkers again, right?
Any OCT thickness measurement guide. I mean, it's only about the thickness. I don't think. I mean, if we have 1,000 or 700, then you have to go for the thickness only alone. Is there any comment from?
No, I don't think the thickness should. I mean, we have some patients also. We have huge.
I think the basic is that if you don't see a good response with the anti-VEGF, we talk about anatomical response, which has been defined as anything better than 20%. Then I think whatever the thickness is, you probably want to consider switching into steroid. So there's not necessarily a specific thickness that you look for.
Okay, can we have, there is Dr. Muhammad Qannas, if he's still with us and he wants to ask or anything. And meanwhile, they open the mic for Dr. Muhammad. I think the top up from, I have little experience with the Iluvien. And after sometimes if there is, the patient is responding, then start deteriorating. And I feel if the deterioration very fast, going very fast, I try to top up with steroid so I can have a fast response. Then the Iluvien can continue to maintaining for long, and I have experienced some cases like this. While in case there is only a little bit change, or you can say not that much change in the OCT thickness and the vision, maybe not a good parameter, but the thickness is more, then I will select the anti-VEGF. I try like this and it's worked, but it's not general rules. This is my comment about that one. So Dr. Muhammad, he is there? Muhammad Qannas, can you open the mic? If not, I think we are already get to the end of this meeting. We are running behind the times more than 40 minutes, but it was a great discussion. It was a pleasure to have all of you. Dr. Carlos Pervizio, it's the first time we saw you, and we hope that we will meet again and again. We thank you for sharing your experience, a very good and excellent experience in Iluvien, especially with uveitis. Dr. Carlos, I know you are a dear friend, and we know long time we know each other. Thanks for the very interesting cases. Dr. Ahmed Al-Barqi, my dear friend, and also Dr. Saad Wahib, real friends and my brothers. And we wish you to pray for us because you are near to Mecca. We are very far now, nowadays. Pray for us. And I want to congratulate everyone everywhere in the world for Ramadan is coming, Ramadan Kareem for everyone. And our meeting in the future, it will be in Ramadan. So I want to announce that in Ramadan, every Friday, we are going to have one posterior segment symposium. And on Saturday, we are going to have an anterior segment symposium. There is a survey is running there. So we want the host and all, we want our attendees just to answer this question to improve our meetings in future. Thanks all of you. If there is any word or any comment from any one of you, I am ready to listen, please.
No, just I need to thank you all my colleagues, Carlos, both Carlos. It's a pleasure to be with you.
On the left, yes.
And I hope you stay safe. I hope the situation in UK and Spain become under control soon, inshallah, very soon. And all of the best for all of my friends, also my colleague Saad, Dr. Saad, and you, Muhammad, and all the attendees. I wish you all the best and stay safe. And I hope to see you soon.
Thank you
very much. Thank you.
I want to say also to thank also, please, I don't want to forget to thank Alimera.
Yeah, sure. Yeah, sorry.
And for their efforts to be with us during this situation of COVID, and they are well supporting. And I would like also to thank the company managing this one. They are done very well. I think I have the problem of the internet. That's why I failed to present my presentation today. Any comment, Dr. Saad, Dr. Carlos? Anyone want to say something before?
Oh, thank you. Just wanted to thank everybody. It was great. Thank you. And again, everybody stay safe. Hopefully we'll get over this. It seems that Europe has gone over the hump, and hopefully we will follow. And we'll everybody have a good summer. Thank you. Thank you. It's great.
Thank you all. It was a pleasure sharing the session with all of you. A lot of interesting cases, and I've learned a great deal. So thank you all for that.
Yeah.
Okay, thank you. Good night, or we'll leave now. Thank you very much.
Thank you. Bye-bye. Take care. Bye-bye.
Bye.